Hello, I'm Dr. Stephen Hanks, Chief Clinical Officer and Chief Operating Officer for St. Peter's Health Partners, a member of Trinity Health. In announcing plans for new St. Peter's Hospital in 1928, the Most Reverend Edmund F. Gibbons, Bishop of Albany, said, "A hospital cannot stand still. It must grow and develop." Those words ring true today as we present our case to support desperately needed upgrades for St. Peter's Hospital, the flagship tertiary medical center for St. Peter's Health Partners. Founded by the Religious Sisters of Mercy in 1869, St. Peter's Hospital is one of the oldest healthcare institutions in New York's capital region. St. Peter's is nationally recognized for clinical excellence in a multitude of areas and is regarded as a regional referral center and a favored hospital for providers not drawn to academic medicine. Our patients value this high level of specialized, compassionate care. They have remained loyal to us because we deliver on our promise as a healthcare organization to provide coordinated ease of access and ease of use across a full continuum of health providers, services, and facilities. But in recent years, delivering on that promise has become more challenging. Many of our patients are not happy, and they let us know it. Our patient experience team hears routinely of long waits and unsafe conditions. Simply put, we are falling behind.
Patients are suffering. So I've had patients tell me they feel like they're down at the morgue.
We had a code in a room where there was no monitoring equipment.
Elderly can't find the unit.
Patients have to wait for surgeries till we have the capacity to take them into ICU.
Current state, we are not able to efficiently and safely care for our patients.
We must upgrade our critical care unit and increase our bed capacity, as well as update several old and obsolete areas on the ground floor. As a tertiary hospital, our ground floor services are foundational, yet most of the areas have not been updated in 30 years. Our imaging department has 2 obsolete X-ray machines that Medicare won't fully reimburse us for. 2 interventional radiology rooms have reached end of life and soon will be unserviceable. But these are not just financial concerns. These aging spaces and technology are impacting clinical quality, and they limit our ability to recruit providers and staff.
It's hard to sell to new hires. They're very apprehensive in coming to a site that doesn't have updated equipment that they're trained on.
Most critically, there is limited space.
So I'm currently in our prep and recovery area, which is the hallway. You can see we can place maybe 1 or 2 stretchers here and 1 more over there. We can't have a stretcher near the extinguisher, the fire extinguisher, so this also limits us. And not only that, but this hallway is used as a recovery area for X-ray across the hall. Definitely a fall risk, and especially after patients have had sedation.
For a service line that performs 5,000 to 7,000 procedures annually, 2 angiography suites simply are not enough. All the restrooms in this department are also not ADA compliant, as again, they have not been renovated in 30 years. Our emergency department is currently seeing the highest level of acuity patients in all of the capital region. Roughly 40% of our patients require a CT scan, but its location is problematic.
The current CT scanner is outside of our department.
It takes roughly 2 minutes to transport a patient from triage to CT. You have to travel through the emergency department, down multiple hallways, through multiple doors, and through separate departments, a literal labyrinth. And that's not taking into account any potential delays that may arise along the way.
We lose minutes every time that we're having to go opening doors, moving through the hallways, and moving the patient outside of an emergency department where we have all of our safety equipment, airway. You're also taking a provider who's in the department, a nurse, a tech, out of the department, which is a safety concern for our patients who they're currently caring for.
The triage area is also not currently suitable to handle patient volume and is also unsafe for our colleagues. The ED also lacks a dedicated observation unit to expedite clinical decision-making. And COVID has reinforced what we already knew, that the current waiting room and registration area in RED is not sufficient.
As you can see when you come in our front doors, we have about a 7-foot area for patients to wait for the registration staff to get them checked in. With 6-foot distancing, this doesn't allow for good space between the patients for infectious disease, and it also causes backup into this front end area.
Our advanced endoscopy department is a center of excellence. Patients travel from more than 100 miles in every direction to seek our care. But for many, finding that care can be a challenge.
The way that it's positioned down here in the ground floor, there's no visibility anywhere, and there's a couple of small signs that kind of direct you to come down the series of hallways, but every day we have patients stopping in the hallway asking, how do we get to endoscopy? And that's really stressful for the patients.
Also stressful for both our patients and our colleagues, there is no dedicated prep and recovery space. Patients have to be transported between floors, posing safety concerns and causing loss of time and potential revenue. The department has no storage space, virtually no space for patient consults, and it even lacks its own sinks.
We don't have any sinks, not one, at the pre and post area to wash our hands, unless we use patients' bathrooms.
The lack of sinks was flagged by the Joint Commission in its recent site visit. Plumbing is also a factor in our critical care capacity.
So this is another interesting characteristic of our old ICU. This is a macerating toilet. Unfortunately, if it breaks, any parts that we need come from England, so it does result in us having to shut down a critical care room for sometimes 30 to 45 days.
Definitely not a patient satisfier either. Those toilets are part of our old ICU on 2 Brady Farrell. The Department of Health shut it down in 2019, not because of the toilets, but because it lacked natural light. The windows you see here are not real. Because of COVID, we were allowed to reopen the ICU, but even so, we lack enough critical care beds. Our current ICU capacity is 28 beds. Based on current demand and projections, we need 40.
We have to really triage the care that we're providing these patients. Because we are consistently at capacity, we have to decide which patients that we have to move out and which patients come in.
When we shut down 2 Brady Farrell, we had to consolidate our cardiac CCU with our ICU, a major dissatisfier for our cardiologists who pride themselves in providing superior care.
Traditionally, we had been known in the community as a heart hospital. Since combining with the ICU, that has limited our ability to take in those cardiac patients.
To improve the safety, quality, and efficiency of our flagship hospital, we need a whole-scale reimagining of how our patients will access our services. The upgrades we are proposing are truly a matter of necessity, so we can continue to be regarded as a regional tertiary medical center, retain clinicians of excellence, and improve the experience of all those within our 4 walls. Our plan centers on improving our critical care capabilities. Not only is this crucial as we navigate through COVID and prepare for the next pandemic, it allows us to maximize space throughout the hospital without increasing its footprint. Our plan will first consolidate our critical care services on 1 floor. By creating a new 14-bed critical care unit adjacent to our existing critical care unit, we can reestablish our cardiac CCU and increase overall capacity to 40 beds. In order to do this, we have to move 30 existing semi-private med-surg beds. Our plan is to move these beds to 3 stacked floors of a building that is operationally connected to existing med-surg units. In doing so, these beds will also become private. After the new critical care unit is completed, the interventional radiology department will move up from the ground floor and fill that vacant space. This will create more efficiencies and help with patient flow. Meanwhile, the area vacated by IR on the ground floor will be used to modernize and expand imaging and endoscopy. A shared front end will be created, and instead of the long, circuitous, and often confusing route to endoscopy, a new hallway with direct access from the front lobby will be built. A new enhanced space would be created for advanced endoscopy procedures with dedicated prep and recovery space as well as increased storage space and sinks. Imaging will also benefit from critical equipment upgrades, privacy for patient recovery, enhanced space for patients and colleagues, and AD-compliant bathrooms. A new entry would be created for the ED, which for many is the front door to our hospital. The new entry check-in, waiting area, and triage would be expanded to address serious safety and privacy concerns as well as growing behavioral health issues. The upgrade would feature a new treatment room layout and a dedicated CT scanner, cutting what was a 2-minute walk out of the department down to a 10-second walk.
This will be the CT scanner suite.
A dedicated observation unit for the ED will be built. This will enhance member safety, improve clinical decision-making, increase capacity, reduce congestion, and improve the overall wait experience. Again, we are falling behind, not leading. Albany Medical Center is less than 2 miles down the road, and we have already lost providers and patients to them. We cannot afford to lose any more ground. This plan will improve access to specialty care by maintaining St. Peter's as a technological leader and promoting recruitment and retention. We can improve access, ease stress, improve efficiencies, and in doing so, honor the dignity of our patients. We can realize higher quality, lower costs, and improved patient health. The total capital request for this replacement project is $113 million. At least 10% of the project will be funded through equity. It is anticipated our foundation will raise $13 million. If we do not take action, we risk losing our GI business to Albany Med. We risk losing clinicians, and we risk our ability to recruit new colleagues. While St. Peter's Health Partners is distinguished in many ways, especially for our vast continuum of care and geographic reach, St. Peter's Hospital is at the heart of our system and key to our future. We've reached a point where something has to change. Just as Bishop Gibbons said, a hospital cannot stand still. We thank you for listening and look forward to your support as we work to advance our care and build for our community's future.